So first of all, let me thank the organizers, and in particular Dr. Emil Hanna and also Dr. Zirah for this invitation to your Congress here in the Kingdom of Bahrain. So today I will try to drive you inside what is the up-to-date in rheumatoid arthritis criteria and therapeutic perspectives that we have for the future. But in particular, where are we now today? I don't know how many of you are familiar with this, but however, I will try to remind you about which were and are now the classification criteria. So in 1987, we had the first American College of Rheumatology criteria that were, we say performant, but still they had a problem. And the problem is, as today we have in all rheumatic diseases, these criteria were not able to catch the early disease. This is a very important issue, and I would like you to really focus on the fact that today we want absolutely to catch this patient in the very early phase of the disease. Now, the current trends is today that we need to recognize the patient as soon as possible. We need to, in particular, to treat them as soon as possible. And obviously, we have a lot of new drugs coming up. Popping up every day, you have new drugs, and I will present to you some of these drugs. So, a common effort between Europe and America, United States, has been to create new criteria to be able to see this patient evolving from the early phase up to the most advanced phase. So that's the reason why Americans and Europeans together have elaborated new criteria. Why? Because one of the main aims of a rheumatologist today is to avoid the evolution of the disease and to avoid in particular the erosion of the bones, because rheumatoid arthritis is a very aggressive disease that is entering the joints and progressively eroding cartilage and bone at the same time. So think of this and think that such a disease can start eating down the joint after 3 months from the very early onset of the disease. And usually, our problem, and we know this, that the disease diagnosis is late. So, if you make a diagnosis 6 months later or 12 months later, you already know that this patient is erosive. Erosion means loss of function. And this is what we don't want. So, as you see here, an erosion is classified as a cortical break in a joint, in the bone of a joint, and usually proximal interphalangeal joints, metacarpophalangeal joints, wrist, as well as metatarsophalangeal joints are the most earliest joints that are involved. Now, you will see now which are the criteria, but we already knew the moment that these criteria were delivered that we still had a hole in this criteria. Nothing is perfect in life, and also all the colleagues, me included, who created these criteria, we knew that we had holes in these criteria, and erosion is one of the holes. So that's the reason why there was immediately a new set of work put up to define specific erosiveness in the joints, and really few days ago, a new paper came out just specifically defining what is a breakage of the bone. And you see, these new criteria have given us the possibility to define with high specificity the cutoff number of erosive joints in order to define rheumatoid arthritis. However, because this is a process going on now, the final criteria, radiological criteria, are still missing. So we need to define really which are, which are the criteria. But let me go back now to the criteria, and you will see what is new today from a few days ago in respect to 2010. You see that in 2010 we were considering these criteria with a score more than 6, identifying definite rheumatoid arthritis. And so we're starting with more than one swollen joint will lead us to rule out the possibility with all these other criteria to enter in the world of rheumatoid arthritis and then start thinking strategically how to approach this patient. But in reality, on top of these criteria today are coming also erosions. So we have to You have to evaluate X-rays and possibly, as you have seen, that we are looking after the new criteria to evaluate these erosions. Probably in the very next future we shall have also ultrasound to evaluate and identify early cortical breaks in the bones. Now, rheumatoid arthritis is a heterogeneous disease. It's not so simple just looking at the joints, because you have systemic manifestation, you have comorbidities, skyscraping, cardiovascular disease. You have mortality increasing enormously in this patient, in particular those who are very badly managed. And you have always the joint damage, and what we are seeking is remission, obviously. So, sustained remission, as well as prevention and arrest of joint damage, is one of the main points, aims that we have, together with the prevention of disability and obviously of comorbidities. Now, when you look at the management, this list seems very simple. We have just to apply this to the patient, but in reality, to have these 6 points working together in a patient is not an easy job. And we have a lot of drugs, starting from the old non-inflammatory to the new coxibs to the very old steroids, moving to the old synthetic disease modifying from gold to chloroquine, penicillamine, up to methotrexate, leflunomide, sulfasalazine, even an association between these, and ending up with today biologicals. A huge number of biologicals that we have on the market now. Now, let me just try to tell you how much it's not easy to see the patient and to tailor on the patient what we want to do, and what we want to do is to achieve remission. So first of all, we have to have a reliable diagnosis, and you have seen the criteria, and we must have an early treatment. This is very important. And you see here that during the first 3 months of the disease, the activity of the disease, it's really popping up and starting to affect the patient. So, the activity in the first 3 months, in reality, will tell you how it will go in the future. So if you are able to strike the patient in these first 3 months, you will be able to predict the remission at 1 year. Very important. Very important. So we have recommendations in reality, just to drive us in this difficult procedure that is the decision on how to manage this patient. So first of all, early diagnosis. We seek for remission, but we accept also that sometimes we cannot achieve full remission, and that's the reason why we stay in what we call low disease activity, just to slow down the aggressive procedure. Then we have a very well-known drug, methotrexate. It's called anchor drug. Methotrexate is the basis drug that is opening the way for the treatment. So this is the first treatment you will use in rheumatoid. But you have contraindication, you have intolerance. So if methotrexate fails, you have leflunomide, you have sulfasalazine, or you can go back even to injectable gold that sometimes, unfortunately, happens in our patient. And then you can combine these drugs, methotrexate with leflunomide with sulfasalazine, and hydroxychloroquine, so you can try to combine these drugs. Now, It's easy to say combine. The problem is how you will combine these drugs, how you will put them up, one after the other, or step up, one on top of the other in different months in the next future, or all together at the beginning. So easy to say, difficult to do. So for this reason, there is something here, number 6, glucocorticoids. And I will show you how important glucocorticoids are just with a simple sentence, okay? Now, let me move here from reliable diagnosis to early treatment to the concept of tight control. And what means tight control? Tight control means you should have a predefined strategy. So you should know what is waiting for you and how you should behave in the next months. And this slide is telling you how much important is the difference between not having and having a tight control predefined protocol. So it's important that you know what is waiting for you. This is not a random job. This is a rational, predefined battle against the disease. So in the last 3-4 years, the concept of treat to target has been developed. And you see here we have the main target, we have the established rheumatoid arthritis, we are seeking remission. However, we know we may fail, we may accept low disease activity. What we want is sustained remission as well as sustained low disease activity. Why? Because we want patients to have their quality of life respected and obviously kept in time. The patient is affected, you treat the patient, you cannot cure the disease, but you can treat the disease. So what does it mean? You will stop the disease, you will keep the disease down, you will avoid the disease to make damage to the heart, to the joints, and this means that the patient will have a decent life in the future. So now the third point is intensive therapy to achieve a tight control. And you see here the difference between having at the beginning only methotrexate monotherapy versus methotrexate plus a biological agent. Doesn't matter which biological agent, but just a biological agent, an antibody in the treatment. And you see the difference of the risk ratio will tells you that the clinical remission is for sure better in the profile of methotrexate plus biological agents. And this is valid also for the radiographic remission. Radiographic remission means no erosions. Clinical control, joint control, no erosions, no progression. So the question is now, should all patients with early rheumatoid arthritis in the very early beginning should be treated also with biological drugs? And you see here, this is methotrexate, this is infliximab, a chimeric anti-TNF antibody with a lower and upper level, 3 and 6 milligrams, and you see the result. There is here a divergence result that tells you that very likely the use of biological drugs from the very early beginning will make the difference. But when you look at the patient, you will consider his conditions. It's clear that a young patient in the early phase of the disease is totally different from an elderly patient in advanced phase of the disease with possibly comorbidities. And so what you will consider are prognostic factors. Factors that are considered bad in the outcome. For instance, the presence of a rheumatoid factor of anti-citrullinated antibodies is a bad prognostic factor. So when you see them, you know that you have to run in order to achieve the disease remission. And also the high disease activity that we have now techniques to measure them. And obviously when you see erosions. This was in 2010, this is 2012, where you see that something has changed because we have added functional limitation. Functional limitation. So bone erosion, rheumatoid factor and CCP antibodies even here the extraarticular disease like the vasculitis, the nodules, and also lung involvement, and the functional limitations. So we have to evaluate all these in our patient. And you look at this trial. This slide is a little bit busy, but I will try to simplify this. This is the best trial. It's called the Matrix for Prediction of Rapid Radiographic Progression. So you see here in red, just look at the colors. Monotherapy, a lot of red. Infliximab, that is the antibodies, combined with methotrexate, a lot of green. So what does it mean? That the treatment, combo treatment, methotrexate plus infliximab, is giving you a reduction of the radiographic progression, significant reduction. Now, moving on again with the recommendation. So we know that disease-modifying drugs may be used in patients with poor prognostic factors, but in particular, combination therapy is what we are seeking for. And obviously, the intensive medication strategy is today what we strongly recommend in the early phase of the disease. Now, let me take you back to the behavioral flow chart. We say early diagnosis, we say start methotrexate, an alternative, you can use all the other synthetic, you achieve tight control. After 3-6 months, if you achieve control, you continue. If you don't achieve, you start changing your mind. You enter phase 2. And also those who have poor prognostic factors obviously should be considered immediately for combination therapy. And now you have a lot of different biological agents. You have anti-TNF, you have interleukin-1, interleukin-6 inhibitor, CD20 antagonist, abatacept, CTLA-4 antagonist, and then we have now coming up even the anti-rankle denosumab. So we have a lot of drugs at our disposal. And we have to make a choice, not easy choice, I have to say. And you see here what is first line, immediate line, then when the first disease-modifying synthetic is failing, then when TNF is failing, and what is in the EULAR, it means in Europe and in the States, first line, consider it only anti-TNF or not all the others. So we have really to cope also with regulations at international level. But if you look at this slide, again, the best trial, you see that if you take only one synthetic versus a combination of synthetic, it's obvious that the combination of synthetic is from far better than only one drug. So again, we know that combination, even at the very early phase, also in poor prognostic people, you can use combination, and we have other trials telling us the same. So, treatment target, if you fail with the synthetic, you should add as soon as possible a biological drug, in particular in those patients that have poor prognostic factors. And now we are here in phase 2. If something goes wrong and this patient is not responding, so what shall you do? Obviously, you will add a biological drug, or you will add a second disease modifying, and if you're not achieving a target again in 3-6 months, you really have a problem. So you have to move on. And you see here, if the first anti-TNF has failed, you have other chances to use other TNF and to be still successful. So you see, this is a procedure that is showing you and is putting you in front of possibilities. In this case, when one has failed, you see the effect of the second is still significant. At this point, you are in this third phase. So you don't respond to the first biological, you change, you switch. For instance, from anti-TNF to anti-TNF, or you swap from anti-TNF to another family. In this case, we are coming almost at the end of our journey, because at this point you start to play with these biologicals. Hopefully you will achieve a target in 3-6 months and you can make it. Yes, you continue. If it's no, you go back and you start again to switch or to swap and to combine these drugs. So what I'm telling you, in a few minutes, it's usually a work of weeks, because you are not only dealing with the disease itself, you are dealing also with side effects of these drugs that sometimes really turn down all your efforts. And in fact, you have to consider comorbidities, you have to consider the predictive factors of severity. I've told you the activity of the disease, and then you have to have a benefit-risk ratio that is very important in your measurements. And here are infections, because infections are a problem for us today. Big problem when you are entering the world of biological immunosuppressive drugs. And obviously, the severity of the disease activity, the age, steroid treatment, the comorbidity, previous infection, joint surgery are piling up to make your life very poor and that of the patient even worse. Because you have to consider all these factors, and you have to go again in those flow charts that you have seen and restructure completely everything according to this. And something else that I will tell you now, very simple, but serious infection are frequent. Opportunistic infection, tuberculosis, is striking in this patient, in particular advanced patient, immunocompromised. Malignancy, fortunately, are not really apparently a problem, and we have other minor problems, but infections are very important. So cancer has been ruled out, fortunately, in rheumatoid arthritis patient on treatment with biologicals. We know this, even if patients that are heavily immunocompromised are at higher risk of cancer independently from biologicals. The increased risk of lymphoma has been ruled out, fortunately, by this study in the Swedish population, and we have good news that the survival is increased under treatment with biologicals. And moreover, today we have the new drugs on the show. Not only monoclonal antibodies. Today we have also small molecules. So the life is even more complex, because all these second messengers have now been developed as possible targets of new treatments. And you see here new treatments. This is already here, already coming up, almost registered on the market. Is the JAK inhibitor, tofacitinib. But you have other JAK inhibitors coming up. You see, you have a psych inhibitor here. So all these companies are developing new drugs. Why new drugs? Because these small molecules are less expensive, because they are small in comparison to the antibodies. And when you look at this, up to now we were out of the cell, we were acting in the circulation or on the cell membrane. Now we are acting intracellularly inside these networks here that are the second messengers that will inform the nucleus through the membrane. So we are here, intracellular now, with these small molecules. So a huge change in the mechanism of action in the pathogenetical targets inside the disease. So at this point, I hope I have given you the complicated life of a rheumatologist in front of a patient. Apparently very simple, we want to achieve remission, but in reality, it's not an easy job. However, the new point that we have today is that we want to understand immediately if a patient is erosive. To do this, you will have MRI, you will have echo, you will have anything you want, but this is the main target you will have as a rheumatologist today, apart all the other criteria you have seen. But here, there is another consideration. You have to optimize the treatment. You have to tailor the treatment. We have the great systems in front of us. We have the beautiful flow charts I have told you, I've shown you, but in reality, you will have to tailor all this complex world to a single subject. So it means that protocols, guidelines have to be humanized to one simple case. And in particular, you will have to respect the patient preference. Because at the end of the day, he will tell you, you know what, Professor, I'm sick of all these drugs. I'm sick of coming every 3 months here. I cannot stand this anymore. And many patients, sometimes, if you are not able to think about their preference, their psychological status, their psychiatric situations, their family problems, and so many other things, you will fail because you have not humanized enough your medicine. And then the choice of the first biological drug today is crucial, very important. Being this an antibody or being this a small molecule, how to combine these two new drugs together with the old synthetic disease-modifying drugs is a real challenge for us as rheumatologists. And with this, I really thank you for your attention. I'm ready to take your questions. Thank you very much indeed.